So the basics of this is going to be for placement of central lines, and we want to be able to make a video so that everybody can review both the indications for it and then placement of the catheter, and then also understanding some of the nuances of placement of the catheter itself. So most of us will be placing right internal jugular central venous catheters. That'll probably be about 90% of the catheters that are going to be placed in the ED and the ICU right now in our hospital. Maybe that'll change in the future. So first thing is that in our ICU rooms, there's curtains that kind of come along the edge, so you want to tilt the bed slightly on an angle away from the curtains so that you have room where the curtains aren't touching your sterile equipment. I like the ultrasound opposite of where I'm going to place the line. So if I'm placing a right internal jugular line, I'd like the ultrasound on the left-hand side so that the probe doesn't fall off. The first thing I would have done is obviously spoken to the patient or a surrogate or a power of attorney or a healthcare power of attorney and gotten consent for placement of the line beforehand. After I've done that, I like to look at the patient's anatomy and decide, am I going to be able to place this line? First, particularly in patients who have had catheters, like dialysis patients, and now they have a fistula. I know that in the past they might have had a dialysis catheter in their neck. So not only confirming the patency in one location, but in several locations. So I usually start here and then progress approximately all the way to the clavicle, and then make sure that the IJ is open the whole way, that there's no narrowing, and that there's not going to be any stenosis proximally that's going to cause a problem for the patient. So once I've verified my site and I know that this is where I'm going to go, the access looks reasonable, the vein looks like it's open, then I would get ready with my equipment. I would open up my tray here and then kind of have everything available immediately to me. I would lay the patient flat. Sometimes people put people in Trendelenburg to make the IJ a little bit larger. One of the mistakes I think that's made is an aggressive head tilt towards the patient's left. Sometimes we'll move the carotid underneath the IJ and cause it to be posterior to it. A slight head turn will just give you enough room to be able to place the catheter itself. So I don't usually have them try to turn so their whole body is facing the opposite direction. I think a slight turn is more advantageous in keeping the carotid and the IJ lateral to each other. So then the next thing is you're going to have all your equipment, which we have here on the bed, and we're going to open that onto our tray table, which we've opened. And you're obviously going to do this in a sterile fashion, so usually saline flushes, 2 to 3 flushes will be needed. And you don't want to make a mess, so you can keep all your stuff together. It's often nice to have a garbage can here if you can to throw all of your stuff in when you're done. So after you place these, 3 saline flushes, the caps for the central lines that we have here, and you'll need 3 of those. And then you're going to need a probe cover. So once you've got that, you're going to throw this equipment into the garbage. Not going to use that anymore, and now you're going to get sterile. You've already prepped the patient once, and everybody kind of does this differently, but I think, wash your hands, clean your hands first, place your mask and your cap on. I think if there's a bunch of wires, and I'm going to take this off just so it's easier to hear me, but once there's a bunch of wires here that are connected to the patient or lines or IV tubing, a lot of it is in an arm or in the leg. So I actually try to move the poles if I can down there so that everything isn't draped here and people are trying to step over that. It's really nice to have this area completely clear of anything before you start. Obviously, if the ventilator's here, you like the ventilator on the left side so the tubing can go over that way versus draping over where you're going to be placing the catheter. So I think that is the most optimal positioning of the patient and kind of getting everything organized before you start. Then I'll open my gloves and have my gloves open on the bed, either in front of me or somewhere nearby on the table. Take my gown. And if you're by yourself, one thing that I do is you can grab the back here sterilely and put this on so it doesn't come off. If you have a colleague, then you can have them come behind you and place that for you. Place your hands through. So once you've got your gloves on, then you're going to go ahead and place the drape on the patient. So you've already cleaned the patient once with a ChloraPrep. You'll clean again One thing that I do is the nasal cannula oxygen often gets in the way, so I like to take it off that ear and tape it on the other side. If the patient has a gown, I open up all the buttons in the right arm so that the gown doesn't come up underneath the sterile area. If the patient has EKG leads, I try to move those off. So again, those aren't coming up where we're going to be placing the catheter. And then we're going to take our drape and look at where the physician says head, obviously towards the top of the patient's head. We're going to pull the sticky tags off and place over where we think we're going to be placing the catheter. And if you have a friend that's there, they can pull the distal end of the drape towards the patient's feet. In this situation, you kind of just have this here and place the sticky portion over where you think the catheter is going to be placed. Invariably, at this point, something may have gotten into that area, or something that was unsterile may have kind of draped up underneath there. If you have somebody there, pull that out of the way. Open up the chloropleth that comes with the kit and re-prep. So now that the neck is prepped, clean, and there's a sterile drape and you're clean at this point, you're ready to start with your line. So I usually would have prepped my catheter beforehand. I didn't do that in this situation, but usually I like to keep the patient underneath the drape for as short as a period of time as possible. They get anxious underneath there. It's uncomfortable to have a plastic bag placed over your head this way. So if you have a nurse here, sometimes just giving them a little tent will make them feel comfortable, like they can breathe well. The other thing is to just kind of allow this to stay here for as limited a period of time as possible. The next thing I'll do is I'll take my two caps and I'll put them on my blue and my white ports. Remove the old plastic caps that are there. And then I'll flush the ports so I clear any air out. Not everyone does this. I do this every time, so I flush it so that there's no air inside the port itself. I'll flush the brown port as well, but leave that open because that's where my wire is going to be coming through. So the brown port will be flushed, and I'll leave this open. Okay? I'll then use the lidocaine that comes with the kit and draw up some lidocaine with my 18 gauge blunt and my 3cc syringe. Take off my blunt gauge needle, and depending on the patient's size, either use the small catheter, or if I'm going to need to go more distally, I'll use the longer catheter. So for needle. So this is very obviously small, mostly just for a skin nick and a very superficial vein. Or much longer for somebody who may need a deeper injection and has a bigger neck. I also go deeper than just the skin, so some people just do a wheel. I like to go deeper depending, because when you're dilating it can be uncomfortable. So I would go deep, watching with my ultrasound as I go in. It's almost like a practice run to inject the lidocaine superficially in the skin and then deeper as I get closer to the vein itself. Once that's done, I'll place my needles into my needle holder here. And I like to do that afterwards. I don't like leaving the needles open on the kit. I don't know who's going to be in there helping with us, or if I should need something and somebody has to put a sterile gown on, and then there's open needles there. So I always place them in there when I'm done. So now we've numbed the patient. We've identified our target previously. We've got our ultrasound. We've left jelly on top of the vascular probe on the ultrasound so that when we're ready to go, there's gel there. There has to be an interface. If there's air between the ultrasound and the patient's skin, you won't see anything, or it'll make your images dampen. So it's important to make sure that you have a layer of gel on first. It's just much easier to do it that way. Then once you're here, you want to grab so it comes out of the kit like this. You're going to open it up and put your hand inside if you're by yourself. If you have a partner there, they can hand you it and then drop it and pull it this way through the sleeve. But if your hand is inside here, you can literally come over here and then grab the ultrasound this way. Pull it up in the air, and then just pull the sleeve down sterilely. Making sure that you have gel at the top is really important. You can leave this opposite, and then grab your rubber bands to keep the gel in place. Everybody does this a little bit different. I like to tape it just in case the patient moves or there's unexpected movements. So this is the tape that comes with the kit, and then I'll tape it across their chest. making sure I have enough laxity to be able to use the ultrasound probe. And we're ready to go. So now we've got the ultrasound in place. I've got my jelly here that came with the kit. We're going to go ahead and place a little bit of jelly on the patient. Next thing that will happen is I'm going to make sure my indicator is pointing towards the same way it is on the screen. And then make sure that right is right and left is left. Okay. So now that I have that, I'm going to take my needle for my lidocaine and go ahead and inject it into the patient. Since I've already put that in there, I'm not going to demonstrate that, but basically going into the skin and not making a wheel, and then going distally closer toward the vein itself. Then once I'm ready to actually gain access to the vein, and I think this is where a lot of this, the skills of placing an ultrasound come in. I like to have my wire very close to me, so I actually will put it here. Some people don't like to put anything on the bed. I like to have the wire close so that once I reach the transition from the needle to the wire is very simple. And now I'm going to have my needle, I'm going to have my wire next to me, and I'm going to put the ultrasound directly in front. One of the things that you want to do with the ultrasound is make sure that it's perpendicular to the vein. A lot of times people will have the ultrasound placed and tilted. The ultrasound is just shooting two-dimensional rays that are coming out of it. So if the ultrasound is tilted this way, it'll be pointing towards the patient's head. So by the time that your needle reaches the patient, it may have already gone past where the ultrasound is. So it's nice to imagine where the vein is in the patient and have the ultrasound be perpendicular to that point. So I've got the ultrasound here kind of pointing perpendicular directly to where I think the vein is. I've identified what looks like the vein, although in real life it looks definitely different than this. There's not usually a bright white structure around it, but we'll work with what we got here. And oftentimes you want to have the needle guide on in the middle just because it guides the middle of your screen. It makes it easier to know exactly where you're going to go in. The way you would do this is enter in usually 30 to 45 degrees. Ipsilateral nipple is what is frequently taught for blind IJs. With the ultrasound, you're just going to kind of adapt based on where you are. So right here I can see I'm directly at 12 o'clock on the anterior wall of the IJ. So I'm going to, at this point, start to aspirate as I go in. I get nice return. As I did that, one of the things I did is I took my left hand and I dropped the probe. I then took my left hand and placed it on the patient, and I'm holding the needle like I'm playing pool. So it's in between my two fingers, and I'm taking my right hand and I'm unscrewing the catheter that way. As I do that, I'm going to pick up with my right hand the wire, and then I'm going to place the wire through. What I'd like to do is I'd like to get to about 10 centimeters, and then I actually pull back my hand with the wire in it, and then push my thumb down and advance the wire in that way. So I actually can feel the wire as it's going in. Not everyone does that. Some people just advance it this way. That's okay too if you do it that way. But just explaining another option of actually feeling it as I'm advancing it, the catheter in. So I can actually feel that it went in, and now it's hitting resistance about 25 centimeters. Once I do that, this piece is going to come off. This hand is going to grab, my right hand is going to grab the needle from my left hand, which has been stable this whole time. If the patient had moved their head, my hand would be very stable with where the needle is. My right hand will grab the needle. If I have a 4x4 here, which I would have liked to have put up beforehand, I would take the 4x4, take it here, over where the needle is going to come out and hold a little pressure in case there's bleeding. And then take the needle out and place it in the safety bin there. So at this point, I've hopefully aspirated venous blood. I've placed the wire into the vein successfully, and I would be confirming the placement of my wire inside the vein. One of the things that is really important here is that most people, if they make a mistake here, is they go past the vein as they're entering with the needle. They go past the vein, and then they aspirate, they get blood flow, and then they can't pass the wire. So at that point, 90% of the time, you've just gone too deep. Got a little excited and advanced the needle. So just pull the needle back slowly, and you'll start to see venous return flow. Or you can actually put the catheter, this syringe back on top and aspirate as you pull back out slowly, and you usually have gone through the vessel. And when you traverse back out, you'll go back through the vessel on your way out. And then you can place the guide wire back in. So now at this point, we assume that we have the catheter, the wire inside the internal jugular vein, and we're going to confirm. I like to confirm in 2 dimensions. So the first dimension would show my wire here. I can actually see my wire entering the vein there, so I can see it in the subacute skin there, and then as it approaches the vein, I can see it enter, and now I know it's gone into the vein there. And then distally, I can actually see it riding inside the vein. You can actually see right there, the wire is located right there, and it's riding along the edge of the vein. The other way you can do this is in longitudinal access, so actually cut the vein in half and watch as it enters here. Now you get a little bit of refractory imaging here, the mirror imaging that you get from the ultrasound, but you can actually see my wire enter the vein there and ride the vein down. So you can see my wire there. and riding the vein down. Now if I go medial, we'll find the carotid, which is right there. And there's no blood flow in it obviously here, so it's a little bit harder to tell, but you can see the wire and then the J-tip kind of going inside the vessel there. So now I feel comfortable that I've placed the wire inside a vein. I've confirmed in 2 dimensions with my ultrasound that the wire is inside in the vein. It didn't go through the back wall into the artery. So now I'm ready to nick. Since you've numbed the skin here, right where the wire has gone in, it shouldn't be painful. I usually remove the blade from the kit there, and you're not going to cut the wire. So some people will tell you to leave the needle on as you go in. I don't do that. I usually take the needle off, and then I actually leave the blade here, and I'll take the non-sharp portion of the blade and ride it down the wire, and I'll point the sharp edge just slightly away from medial, because that's where the carotid is. Not that I'm going to go deep enough to get that, and then just ride the needle down, and then make a big enough nick that I can actually cut through the skin there, and then also a little bit of the subcutaneous tissue. You don't have to go as deep as where the vein is. That's not the part that's going to be difficult to dilate with. After you've done that, you're going to want to grab the wire and make sure that it's mobile in the nick that you just made. And sometimes in obese patients, the skin will flop backwards, so you'll need to use a gauze tissue to pull and retract the skin to make it nice and tight as you nick the skin itself. So once you've done that, you've got the wire inside the patient. You've pulled back and recognized that. You can move your wire freely in the patient's neck, knowing that dilation will be very simple. The next thing that you want to do is with the dilator, you want to pass this through. Now the wire should not move. The wire is just the tracks that the dilator is going to ride on. So you want to make sure that as you pass this in, the wire doesn't move at all. I like to grab the dilator close to the tip, and it's more of like a push and a screw method as you go in. If you have a friend, it's nice if somebody's sterile with you to be able to take a 4x4 gauze, especially for dialysis catheters, and to pull the skin behind to make it nice and taut as you go in. So actually retracting behind as you go in the skin is very helpful. And dilate a little bit, especially with bigger dilators, but the triple lumens is not as much of a big of deal as it is with a dialysis catheter. As I dilate, I slowly twist and turn. I like to grab my wire behind and make sure that my wire still moves freely. Dilate a little bit more, make sure my wire still moves freely. Dilate a little bit more, and make sure my wire moves freely. With a triple lumen, I may not do that, but with bigger catheters, larger catheters, I will definitely do that. So, with a triple lumen, this is a flimsy catheter. It's unlikely to perforate the posterior wall of the vessel. But in case you're using a big 14 French catheter, or you're going in a very stiff artery, and you're using a stiff wire, for somebody who's getting a balloon pump placed or something else, you want to make sure that wire does not kink underneath the skin. So once I've done that, I'm going to take my dilator, and I'm going to pull my dilator out. I'm going to hold pressure there. And people often say here, you're not holding the wire. Now, if you're practicing or you're a novice, you definitely want to have yourself holding the wire, somebody else hold the wire. But the wire is not going to get sucked into the patient unless you push it into the patient. So when this comes out, I will hold a little bit of pressure on the wire and just take the dilator off. And this is holding pressure where I just dilated, in case I dilated the anterior wall of the vessel itself. Once that's done, I'm going to take my triple lumen kit, and if you have a 15 centimeter catheter, you're going to hub it. If you've got a 20 centimeter catheter, you're going to go to like 15 or 16, depending on the patient's size. So at this point, grab the catheter here, slide it over. As you get close to the tip, in most patients, you're going to actually, like here, the wire comes out easily even before I get there, but in most patients, you're going to have this in all the way to 20 centimeters, and it'll be harder. So you actually have to grab here and thread it back out the brown end as you thread the catheter in. Once you've got it out the brown port, your right hand can hold the wire like this. Again, the wire should not move. It's just there to be the guide for the catheter, and then thread the catheter over the kit like this. And then once it's into the correct depth, let's say 15 in this patient, then I can go ahead and pull out my wire. Once my wire is out, there will be blood flow usually returning depending on the central venous pressure of the patient. In patients who are very hypovolemic, it may not, so you want to avoid if they're taking large inspiratory volumes and aeroembolism there. I haven't seen that, but that's definitely a complication that's been spoken about. And so you want to make sure that this patient has fluid about to go through there and a cap on after you remove the wire. You're going to aspirate first, and then go ahead and flush the catheter through, and you're going to repeat that on the blue port. First, aspirate slightly, then flush through. Aspirate slightly on the white port, just enough to see blood come. You don't have to fill an entire container of blood. You're not sending this blood for evaluation or anything. You just want to see that the catheter is patent, and then flush. Then once that's done, if it's 15 centimeters, you're going to have a lot of catheters still hanging out. So I advocate on the right side using the shorter catheter, the 15 or 16 centimeter catheter, so that you can go right to the hilt. It's much easier to secure that way. If you don't do that, then you unfortunately have to use two methods to secure it. One will often be to suture these flanges on the patient here, and then the other will be to suture these pieces directly next to the catheter site of entry. So it is much easier to do that if you have it hugged to the hilt, and then you can either just suture these flanges or use an anchor that uses the non-suturing devices to anchor the central line directly from these tips, which we have in our ICU in the emergency department. So these are the ways that I would secure the catheter. Once the catheter is in place, what you're going to do is take your biopatch. Ideally, the biopatch is supposed to go underneath it, where the actual catheter goes in, so it's going to wrap around it this way. So now you have this here. So now you're nearly done. You've anchored it proximally. You've anchored it distally. Your catheters are in place. There's caps on top of them. The biopatch is in place. And you're going to remove the patient from underneath the sheet. Some of these have tearaways, so it's easier when there's a tearaway to just rip it. If they don't have a tearaway, you can use a knife to cut it. And then just rip. And then take your tegaderm that should be right here and place over the catheter itself. And throw everything away, and you're all done. After you've removed that, now you're going to take all of your sharps that you have here to your sharps container, throw away all the sharps that you have, and then order a chest x-ray and ask the nurse to go ahead and call for stat chest x-ray to confirm placement. Some people, if you want to use it right away, will use ultrasound of the heart and take a look and flush through one of the ports. If all of the bubbles are going on the right side of the heart, it confirms that it's in a venous placement. So that, in an emergency, the patient's on pressors and you can't wait for an x-ray and you don't have other IV access, that would be equally acceptable in terms of identifying the location of the catheter.